Hi everybody, my name is Dr. A. Padmanabhan. I am a senior pediatrician. I am putting a video on a topic which I had blogged just 2 weeks ago. This because I feel that this topic is important at this particular point of time because IAP has come about with this 2021 recommendation of immunization. And I feel that I can emphasize certain points on a video rather than on a blog. So the critical question we are asking today is a booster dose of IPV, injectable poliovirus, required at the age of 4 to 6 years of age for children who have received an initial IPV dose as per IAP Advisory Committee on Vaccines and Immunization Practices Advice, ACVIP guidelines. Is it required? Is it feasible? That is a critical question we are asking today. This is because the advisory committee, the background of this issue is the advisory committee on vaccines and immunization practices of the Indian Academy of Pediatrics in 2020-21 in the draft recommendations as set as advice for a booster dose of IPV at 4 to 6 years of age for children who have received the initial IPV dose as per IAP schedule. Therefore, is it required? And that we will dig deep into this matter because it's critically necessary to understand this. Now let's go into some of the reasons behind or the background reasons why this committee has gone into making this. Now, cases of imported wild polio virus from endemic neighboring countries or cases of circulating vaccine-derived polioviruses remain a real threat unless population immunity is maintaining vaccinating children adequately in the early years of life. There's no doubt about it. Nobody can question this, especially since we have neighboring countries, Pakistan and Afghanistan, which are the only remaining focus for poliovirus in the world, especially wild poliovirus 1. Now, the second matter which is worrying the committee is, which made this recommendation is studies examining the long-term persistence of antibodies following injectable polio vaccination has shown a persistence of antibodies only up to school age entry, with the highest titers observed in 3+1 schedule, and all IPV using countries recommend a school booster. Now, this is a little controversial because we will come in later into this persistence of antibody only to school age entry. And regarding all IPV using countries recommend a school age booster may not be entirely true because only out of 35 Western European countries, only 33 advise the booster dose at school entry. And Eastern European countries generally don't advise a booster. Of course, the America and most of the Western countries do that. There are no studies regarding the long-term persistence of antibodies in the normal schedule which we follow here of 6, 10, and 14 weeks, and 2 doses of fractional doses of intradermal injectable polio. That is also true, but there are no long-term studies of long-term persistence. But remember, in the private sector, normally we give injectable, children do get injectable polio 6, 10, 14 weeks and at 1.5 years. And 2 fractional doses of IPV, of a dose of intradermal polio, IPV, are considered even superior than a single IM dose of IPV. Anyway, we will come into that later. And the committee was also worried of the fact that outbreaks of circulating vaccine-derived poliomyelitis have occurred in countries which have been polio-free for several years. Nobody can question this, but really, is the injectable polio the way forward for this is the question. And after replacement of trivalent oral polio with bivalent polio, IPV is the only immunization which protects against poliovirus 2. That is also beyond doubt a very important concern. Therefore, these concerns have made the committee recommend a booster dose of IPV at 4 to 6 years of age for children who have received the initial IPV as per ACVIP IAP schedule. It also goes on to say a very important statement. In case of non-availability of standalone IPV, this dose can be administered as a combination with DPT vaccine. What is our concerns regarding this recommendation? I particularly feel that the misplaced worries of protective immunity waning for poliomyelitis. Just because the antibody level is coming down, to immediately correlate it with decrease in protective immunity, I think is a misplaced worry. We will discuss it in some detail. And when you give a combination vaccine, the only one which is available is a combination with SLA vaccine. Concern about the long-term immunity to pertussis following administration of AP vaccine as combination vaccine is school entry. These are the two primary things, and we will discuss them one by one. Now, let's take the first one. Let's look into as per the World Health Organization WHO polio position papers in March 2016. I think this cannot get bigger than this. They clearly state there is no evidence that protective immunity against paralytic disease wanes over time. After induction of active immunity, either by vaccination or exposure to poliovirus, usually measured by circulating antibody titer, protection is lifelong. If I'm going slowly so that it sinks into you. However, as antibody titers decline over time and may fall below detectable levels, seroprevalence may not reflect the true immune status of a given population. Therefore, this is given in the WHO position paper 2016, and they have not changed it in the last 5 years. While to drive home the point further, it goes on to state while seroconversion is a reliable correlate of immunity against paralytic disease, there is no evidence that loss of detectable antibody puts immunocompetent individuals at risk for paralytic disease. Therefore, the concern the committee has of waning antibodies to polio virus is a misplaced worry. That's what I feel. Now, if you want further evidence from literature, this statement from the well-known book of vaccines. Studies done with modern conventional IPV containing vaccines show persistence of antibodies only up to school entry age because all cohorts have received a school entry booster with a CIPV, conventional IPV containing vaccine. Because they said they couldn't do the studies, not that the studies are not there is what is emphasized by the committee, but what this book says is, this classical book states is, no studies could be done because most of the patients were receiving, most of the countries were giving a booster at 5 years. And no data are available in cohorts of subjects primed with these different infant toddler schedules, having not received a school entry booster with a conventional IPV containing vaccine. Therefore, there is no data available because most of the patients have already received the booster at 4 years. Therefore, they couldn't follow up the antibody titers of children who were given only infant doses, say at 6, 10, and 14 weeks and at 1.5 years. In contrast to the statement from very reliable sources, two of which I have quoted, the IAP does quote some references for long-term persistence of antibodies. But as I will illustrate in the following slides, they don't seem to be very reliable references. The committee has relied on some studies which are of questionable value. Now they have in study number 8, in reference number 8, they have quoting that they say following a preschool booster, almost 100% seroprotection rate and high antibody titers persist at least for 5 years. This is the only study quoted as evidence for long-term persistence of polio antibodies after immunization at 5 years in this article. But however, among 300 children who participated in the study initially, less than 50%, 146 attended the 5-year follow-up. And to add on to this study was sponsored by Sanofi Pasteur. The sponsor funded the study and developed the study protocol. Employees of the sponsor reviewed the manuscript before submission for publication. Therefore, this value of the study goes down when you have such a statement. Quoting reference 9 of the article, they quote a study in which children receive their primary immunization in infancy and a booster at 12 to 23 months. And in study A, they did a blood level, they did a serological study at 4 to 6 years. In study B, the same booster doses were given, but the children received another booster at 5 to 6 years of age also, and they also measured their antibody level at 7 to 9 years instead of 4 to 6 years. Find out, and now if you look at the green table here, it shows the antibody level measured at 7 to 9 years in children who had taken a booster at preschool, and it's almost 100% for all the three polio viruses. For children who did not receive the booster at preschool booster, when their antibodies were measured at 7 to 9 years, was slightly less, it's around 91, 92%. But however, this article does not discuss this in any detail, and it had also measured antibodies against pertussis, and they say that they discuss the significance of this and nothing about the polio antibodies. Now the committee states, in the absence of a booster at 4 to 6 years, the seroprotection rate against poliovirus 1 and 2 has fallen from 91 to 91% and 91.2% compared to 100% in those who received a school entry booster at 4 to 6 years. This is a fact which is given in the article, but they don't discuss any significance of this. And what's the significance of this fall is not discussed even in the original article. The recommendation quotes from article reference number 10, which is of course a study which is quoted in the WHO website, that there is low scientific evidence of more than 80% long-term, more than 5 to 10-year persistence of protective antibodies following 3 to 4 doses of IPV before school age. Therefore, this looks a reliable quotation, but however, the significance of the low antibody is a different matter. In contrast to this, most of the other references, if you read the references, they do not correspond with the conclusion that is written in the article. For example, the Article 12, quoting Article 12, they say that there are no conclusive studies to demonstrate that the booster response occurs sufficiently rapidly to prevent reinfection or paralytic disease, and that is as effective as pre-existing immunity. Therefore, if a patient he has memory immunity, it doesn't prevent reinfection or paralytic disease. They quote from this study. But however, the study only states, however, in contrast to pre-existing immunity, memory immunity does not protect against viral excretion. It does not say that it does not protect against paralytic disease. This is again reflected in their quote Article 16 and 17. They say this population immunity against poliovirus type 2 has decreased with resultant increase in circulating vaccine-derived poliovirus cases and outbreaks. But however, if you look at reference number 17, if you read the article in detail, the switch from trivalent OPV to bivalent OPV can provide high levels of immunity against type 1 and type 3, but not against type 2, indicating a high risk of type 2 vaccine-derived poliovirus emergence and transmission. Indicating a risk, they only talk about a risk. They don't say that there is a result already seen. Similarly, in article reference number 16, which is referred to in the article, it only found out a declining immunity to poliovirus 2, suggesting that Vietnam is at risk for an outbreak of type 2 vaccine-derived poliomyelitis in case of importation or new emergence. Nowhere in the article is it written that there is a resultant increase in circulating vaccine-derived poliovirus cases or outbreaks. Therefore, there seems to be an anomaly in the references given. and this is reflected in some other references also. So far, we were talking about a concern regarding misplaced worries about protection immunity waning for poliomyelitis. We thought that this worry about the Indian Academy of Pediatric Committee is misplaced. Now, the second point which I want to make is a concern of long-term immunity to pertussis following administration of AP vaccine as combination vaccine at school entry. When you advise injectable polio vaccine, since standalone vaccine is at least not available now and probably will be available is said to be available in a few months' time, you have to give it as a combination, and the only combination vaccine is SLR pertussis vaccine. And regarding this, the waning of immunity, even the Western world is very much concerned about. If you look at this article in Pediatrics in July 2019, SLR pertussis vaccine effectiveness over time, it states, despite robust vaccination schedules and high vaccination rates, many countries, including the United States, have seen large pertussis outbreaks since the replacement of the whole cell pertussis vaccine with SLR pertussis vaccine. In 2010-14, the California experienced two large pertussis outbreaks with 9,000 cases each. Most pertussis cases occurred among age-appropriately vaccinated children, suggesting that suboptimal dose effectiveness played a major role in these epidemics. Remember, this is from a Western journal itself. Now, I will quote further from another very prominent journal, the New England Journal in 2012, which specifically talks about waning protection immunity after the fifth dose of SLR pertussis vaccine. It states, evaluation of data from a large pertussis outbreak in California showed that the protection of the disease after fifth dose of DTaP among children who had received DTaP vaccine was relatively short-lived and waned substantially each year. Two prominent journals, very famous journals, have commented on this. Now, it is not the Western journals alone. The IAP Guidebook on Immunization 2018-19 stated reasons for the resurgence of pertussis in a number of countries were found to be complex and varied by country. The shorter duration of protection and probable lower impact of AP vaccines on infection and transmission are likely to play critical roles. Play critical roles. Many studies in industrialized world document faster waning of AP vaccine, and they have showed protection only up to 4 to 12 years. Now, even the position paper in 2013, even as early as 2013, position paper of the Indian Academy of Pediatrics on pertussis made a categorical statement. There are multiple factors responsible for the recent resurgence of pertussis in industrialized countries. They include enhanced awareness, increased public health reporting, introduction of more sensitive tools like PCR for diagnosing infection, etc. But the major factor is the lower efficacy of AP vaccine when compared to WP vaccine. Therefore, after having made all these statements, I don't know how the ACVPI committee can now advise a combination vaccine with AP vaccine at the age of school entry. Now, one of the factors that is often put forward is most of the Western countries do give a booster school entry, therefore it is required. Now, but they do give booster dose in different regimens. For example, the USA gives at 2, 4, and 6 to 12 months, and a booster at 4 to 6 years. That is 2 plus 1 plus 1. Or sometimes they give 3 plus 0 plus 1. That means the booster is not given at 15 months. They give at 4 to 6 years. Total, they give only 4 doses. Now I understand they're planning to give a dose at adolescents also. Now UK, on the other hand, gives a dose 2, 3, and 4 months and 3 to 5 years. Only in other words, 3 plus 0 plus 1. Or they don't give a dose at 1.5 years. But the UK gives a booster dose at adolescents at 13 to 14 years over and above the school entry dose. Some of the European countries do give 3 plus 1 plus 1, as is often given in the private sector in India. Now, there is something called, many countries go on to develop booster even in adolescents, like Austria, France, Netherlands, etc. Some others don't do. Therefore, there is a varying. So therefore, how long to chase, how much to chase this lowering antibody is a question for every country. For developing countries, IPV is costly, not easily available. Therefore, you can't be giving repeated doses of IPV. That would not be a priority. But remember one thing, there is a lowering of immunity in adults, waning of immunity in adults. No country gives a booster. If your worry is that you should eradicate polio, therefore you should have antibodies in the whole population, you should be giving booster for adults also, which is not done in any country. Therefore, to argue that you have to uh, give boosters at school entry, even though there are no paralytic poliomyelitis reported in patients who have taken 3+1 dose, then you should be giving boosters even in adults. That's not a correct argument to make. Even the WHO is concerned about the waning of immunity to type 2 poliovirus and the risk of developing circulating vaccine-derived poliomyelitis. Therefore, meeting of the strategic group of advisory group of experts on immunization in April 2018, their conclusions and recommendations of IPV, because IPV is the only one which protects against type 2 now, suggested implementation of a routine immunization schedule with a minimum of 2 IPV doses, full or fractional. In fact, now they say fractional dose is very effective. It should not be called as fractional. They say they should be called as intradermal only because it's quite effective as the IM dose. Standalone or in combination vaccine with the first dose administered at 4 months and the second dose at an interval of at least 4 months after the first dose. Therefore, they are telling only about 2 doses. There's no recommendation for a booster at 1.5 or 5 years. And now they have a typical strategy for type 2 circulating vaccine derived poliomyelitis, which is, and they have produced an addendum from 2019 to 2023. They are given definite advice for global polio eradication initiative. They have a plan for from January 20 to July 21. I mean, if you go ahead with it, you will find that this is global polio eradication, circulating vaccine derived poliovirus type 2 strategy. They have a definite strategy. And it says about IPV catch-up campaigns and targeted use in outbreaks where warranted. It doesn't talk about a booster dose of IPV to prevent circulating vaccine derived poliomyelitis. It doesn't do that. And it gives more importance to increase of a novel OPV2, which will lessen the risk of new outbreaks. I don't know whether it has rolled it out. It's supposed to have come into the started doing it from August 2020 onwards. It has a definite plan right up to 2023 what to do at various stages. But at nowhere is a booster dose at school entry one of the factors. Lot of literature regarding circulating vaccine-derived poliovirus comes from China, and they have even reported paralytic cases of circulating vaccine-derived poliovirus type 2. This is because a lot of Pakistani labor work in China because of the Belt and Road program initiated by the Chinese government. But even they have, see, have introduced only a second dose of IPV in the routine immunization program and adjusted the routine immunization program to 1 IPV and 3 bivalent OPV. From 1 IPV and 3 bivalent OPV to 2 IPV and 2 bivalent OPV since January 2020 to sustain the high population immunity against type 2. There's no they have not even given a booster at 1.5 years, let alone at school entry. Wrapping up this presentation, the answer to the critical question is a booster dose of IPV at 4 to 6 years of age for children who have received the initial IPV dose as per IAP Advisory Committee on Vaccines and Immunization Practices, ACVIP, required and feasible. I would at least say that it's not a priority. I would even say that it's not required, and it is not feasible at present. Because a standalone IPV is not available, at least for the present, The committee advocates a tetraxib, DTAP, IPV at school entry. The committee's concern has given precedence to waning polio antibodies to pertussis protection. Now, if you give AP vaccine, the waning of pertussis protection is well proved, and this is disastrous even in Western countries, because when adolescents and adults suffer from pertussis, newborn babies and even early infancy children do get pertussis before the protection from the immunization can kick in, and this carries a very high mortality. As far as the waning polio antibodies are concerned, as per WHO, there is no evidence that loss of detectable antibody puts immunocompetent individuals at risk for paralytic disease, and IPV booster is not part of global polio eradication initiative, circulating vaccine-derived polio virus strategy. Now, no reports of any child developing paralytic poliomyelitis after 5 years in children who have received the initial IPV doses as per IAP schedule, as far as I know. I may be wrong in this, I have never seen. Even this, and further, there's a lot of fear psychosis generated by circulating vaccine-derived poliovirus cases reported. They are both paralytic and non-paralytic, are reported and updated in the WHO website every month. But the immunization status of those children are not reported. If no paralytic or non-paralytic these cases are occurring in immunized children, especially paralytic cases are occurring in immunized children, I don't know why so much of significance should be given to that. Therefore, final message to the Indian Academy of Pediatrics Advisory Committee on Vaccines and Immunization Practice is that they should immediately withdraw the recommendation. In case of non-availability of standalone IPV, the dose can be administered as a combination with DPT vaccine at school entry. I would even add that even when the standalone IPV is available, it shouldn't be a priority to administer at 5 years of age. Thank you for listening so long. I've been putting up videos taking up one single issue which is of importance to practicing pediatrician, and everywhere, whether it's a primary, secondary or tertiary care. And I try my best to dig deep into the literature and come about with my own experience. The videos you can find in this particular web address, and the blogs you can find in this one. I blog on pediatric theory and practice wordprocess.com. Thank you very much, and goodbye till we see next time.